This is lecture 2 on the liver. We're going to cover liver pathology. It's chapter 9 of your Hagen Answered. In this lecture, we're going to cover developmental anomalies. We'll talk about diffuse disease. We'll discuss portal vein hypertension in the presence of diffuse disease. We'll talk about biliary obstruction. And then we'll discuss some focal hepatic disease, things like cysts, abscesses, and tumors. We're going to start with developmental anomalies. The first one we're going to talk about is agenesis of the liver. If it's complete agenesis, this is incompatible with life. These babies don't live much past birth. If it's just one lobe or portions of the liver, the rest of the liver will become hypertrophic to compensate, and that's definitely survivable. Other anomalies are anomalies of position. These are things like situs inversus, where the organs are reversed. The liver is on the left side, the spleen is on the right side, or it may even be absent. Diaphragmatic hernias, these are things like when the liver might herniate through the diaphragm and into the thorax. Another one would be something like an omphalocele, where the liver is outside of the abdomen. Accessory fissures are also very uncommon. They're caused by infoldings of the peritoneum. The inferior accessory hepatic fissure is an uncommon true fissure, and it runs from the portal vein to the inferior border of the liver. You will see it on ultrasound as another linear echogenic structure that should be, you'll see it and you'll be like, there shouldn't be a fissure there. That's what it is. If it runs from the right portal vein inferior to the lower margin of the liver, it's probably the inferior accessory hepatic fissure. And then there's vascular anomalies. Hepatic artery origin, you can have anatomical variations in where the hepatic artery takes off. Those are relatively common. Portal vein anomalies are more uncommon. You're going to see things like strictures, valve obstructions, or even portal vein agenesis, where the portal vein fails to develop and they end up with a number of collaterals that take over the function of the portal vein. Hepatic vein variations are going to be the most common thing you'll see, and there's a number of those. The accessory vein can be into the right hepatic vein, or it might be into the mid or even the left hepatic vein. We're going to talk about diffuse disease. Diffuse disease covers a number of disorders, including fatty infiltration, hepatitis, cirrhosis, glycogen storage disease, and hemochromatosis. We'll hit on those all in a little bit more detail here shortly. But all of them, the hepatocellular diseases, are going to affect the hepatocytes and interfere with liver function. The hepatocyte, you'll recall, is the liver cell, and it performs all of the functions that are ascribed to the liver. So diffuse disease is measured through a series of liver function tests. You'll recall we talked about those. There were the AST, the ALT, the alkaline phosphatase, and the bilirubin, both conjugated and unconjugated. Those hepatic enzyme levels will be elevated with cell necrosis. So fatty liver, this is an acquired disease. It is reversible. It's a disorder of metabolism, and it results in accumulation of triglycerides within the hepatocytes. So fatty infiltration implies that there's an increased lipid accumulation in the hepatocytes, and it's the result of major injury to the liver, or it can be a systemic disorder that leads to impaired or excessive metabolism of fat. It can be the result, as we said, of injury to the liver through things like diet, alcoholism, and numerous other problems. We can see fatty infiltration on ultrasound. So if it's mild, you'll see a minimal diffuse increase in the echogenicity of the liver. It'll be slightly increased compared to the kidney. And you'll still be able to see the diaphragm just fine. The intrahepatic vascular borders will still be easy to see, but it'll just be slightly brighter than you would expect it to be. If it's moderate, you're going to get increased echogenicity with slightly impaired visualization of the diaphragm and the intrahepatic vascular borders. So it becomes what we call dense, and those vessels and that diaphragm become harder to see. If it is severe, there will be a significant increase in echogenicity of the liver. The liver itself will be very bright. You will have decreased penetration of the posterior segment of the right lobe of the liver. You get a lot of attenuation of the ultrasound signal, so the bottom portion or the deeper portions of your image will be very dark, and it will be very hard to see the diaphragm and the hepatic vessels. So here's an example of that fatty infiltration. I would call this mild to moderate, and you can see here that we've got the liver. We can still see that diaphragm pretty easily. Not a lot of vessels to make out in this section of the liver, but we can see the kidney here. Remember I said we're going to compare the kidney to the liver. Notice that the cortex of the kidney is significantly darker than the liver. The liver is hyperechoic to the cortex of the kidney, which indicates to us that there is fatty infiltration of this liver. Fatty infiltration is caused by a number of things. Obesity puts you at risk for fatty infiltration because the fat has to go somewhere, so the liver ends up storing excess fat. Excessive alcohol intake can interfere with the hepatocyte function. Poorly controlled hyperlipidemia, so high cholesterol. Diabetes is a big one. A lot of times obesity and diabetes, of course, go together, and both of them are considered disorders of the metabolism. Excessive use of corticosteroids will cause fatty infiltration. Just being pregnant will cause fatty infiltration of the liver. Being pregnant will cause all kinds of wonderful things that you have to recover from. Total parenteral nutrition. So this is IV nutrition when for some reason the patient cannot ingest food through the esophagus and the stomach and have to get their nutrition via IV. This tends to be really hard on the liver. Severe hepatitis, glycogen storage disease, cystic fibrosis can cause fatty infiltration. Certain drugs can cause fatty infiltration, and chronic illness. All of those conditions that we discussed on the previous slide will cause fatty infiltration of the liver and diffuse increased echogenicity. Sometimes we're going to have areas of the liver that are still normal. They don't have fatty infiltration yet. The fat has not infiltrated into those normalized sections of the liver. They're going to appear hypoechoic to the rest of the liver and can be mistaken for masses if you don't become aware that the liver itself is actually diffusely diseased and hyperechoic. So these hypoechoic areas that are actually normal liver tissue can be mistaken for mass. The most common areas where you're going to see focal fatty sparing are going to be the anterior to the gallbladder and around the portal vein. And so if we're looking at this picture right here, we can see this whole picture is liver, right? And we got hyperechoic liver on this side. We got hyperechoic liver on this side. And right through the center, we have an area of the liver that has been spared from that fatty infiltration. The next disease we're going to talk about is viral hepatitis. This is also a diffuse disease. It's the general name for the inflammatory and infectious disease of the liver, and it comes in different types. Type A is found all over the world. It's spread primarily by fecal contamination, and because it lives in the digestive tract, in the alimentary tract, that's why it comes out through the feces. It's endemic in developing countries. We do have it in first world countries as well, but not at the same levels as we see it in developing countries. This is an acute infection, and your options are total recovery or death. That's it. You either completely recover from it or you die. Now type B is caused by the type B virus, and it exists in the bloodstream. So it can be spread by transfusions of infected blood or plasma. It can be spread through contaminated needle use or through sexual contact. And this is the one that we vaccinate against. And then type C is diagnosed by the presence, by its presence in the blood of the antibody to HCV, also known as anti-HCV. Hepatitis can come in two forms, acute or chronic. Without complication, clinical recovery from acute hepatitis is usually going to occur within 4 months. So if it's acute hepatitis, it should clear up within 4 months. Chronic hepatitis is going to exist when clinical or biochemical evidence of hepatitis inflammation is still there beyond the 6-month mark. So you've got that sort of gray area between 4 and 6 months where we're trying to decide if it's acute and it's going to resolve on its own, or if it's going to become chronic hepatitis. Chronic persistent hepatitis is a benign self-limiting process. Chronic active hepatitis is usually going to progress to cirrhosis and liver failure. So the hope is it's acute and it resolves on its own within 4 months. If that is not the case, then the next best thing that we can hope for is that it becomes chronic persistent hepatitis, which remains benign. If it becomes chronic active, then we have to be concerned about liver failure and cirrhosis. So sonographically, what's it going to look like? It tends to give the liver a very coarse look to the parenchyma. And so we talk about, homogeneous versus heterogeneous. Normally we like to see a homogeneous liver where everything's kind of smooth and the same texture. Hepatitis, we're going to hear called starry night. So sometimes it's called the starry night, and you're going to see a lot of bright echogenic foci within that liver. This whole thing here is all liver. Okay, you got IVC down here. We've got probably portal vein right here. Not too sure about this. We don't have color Doppler, so don't know exactly which vessel or duct that is. But see all these little bright dots. 1, 2, 3. There's more over here. 4, 5, 6. They look sort of sparkly. Those are that starry night process that we talk about. And you can see it here in this section of the liver as well. So here's another liver with hepatitis, and you can see that we've got these areas of very bright, dense liver tissue. We've got some shadowing going on. We've got some areas of increased attenuation where the posterior part of the liver is darker and harder to see. Overall, it has a very heterogeneous appearance. Cirrhosis is a chronic degenerative disease of the liver. The lobes are going to be covered with fibrous tissue, so you get fibrotic scarring in the liver. The liver parenchyma is going to degenerate, and the lobules are going to be infiltrated with fat. So you have a number of different things going on. You get that fatty infiltration, then you get necrosis in there, and then you get scarring over where the necrosis or the liver attempts to heal itself. But ultimately it's going to fail. When it scars over, that part of the liver becomes non-functional, and then it tries to regenerate. So you end up with this very, again, heterogeneous look with portions of the liver that no longer function. And eventually the non-functioning parts of the liver overtake the functioning parts of the liver. The essential feature is going to be that simultaneous parenchymal necrosis with regeneration and diffuse fibrosis. So you get a disorganization of the lobular architecture as well. So you lose those nicely defined lobes of the liver, and you start to see a disruption of that. You'll start to see that some of the liver overgrows itself and other parts start to degenerate. Cirrhosis can have a number of different appearances, but most of them are going to have some things in common. One of the things that you're going to have is a very bright liver. It's going to be hyperechoic. In addition to that, you're going to have increased attenuation, so dense areas of the liver. Notice in this picture here, this posterior part of the liver is necrotic and dense. Okay, so we start to see necrosis of the liver. Up here, we've got that dense hyperechoic tissue, which is the fatty infiltration. This one has some necrosis down here. Over here in this image, the whole thing is very much fatty infiltrated. And then notice up here that right at the top of our screen, there's some black. That's fluid around the liver. Down here we can see it even better. We've got an atrophied left lobe of the liver, and then we've got ascites surrounding the liver. So as the liver goes into cirrhosis, it's initially going to get enlarged. And then as the necrosis and the scarring happens, that liver is going to start to atrophy and shrink, and that's when you start to see ascites. Cirrhosis tends to be both chronic and progressive with liver cell failure, and at the end stage, you're going to see that portal hypertension. We're going to talk about portal hypertension in a little while. Remember, I said we see it in the presence of diffuse disease. One of those types is cirrhosis. Micronodular cirrhosis is most commonly the result of alcohol abuse, where macronodular cirrhosis is usually caused by infection of either viral hepatitis or another infection. Other causes of cirrhosis, because it's not always hepatitis or alcohol abuse. You can have biliary cirrhosis, which comes on because of chronic biliary disease, such as gallstones. You can have Wilson's disease, primary sclerosing cholangitis, which is an inflammation of the bile and hepatic ducts, and hemochromatosis is also another reason to see cirrhosis. In addition to that, we have seen a rise in non-alcoholic fatty liver disease that progresses to cirrhosis. It acts just like alcoholic fatty liver disease, but it's in people who are, it's not caused by alcohol, it's caused by diet. That standard American diet, SAD, like I like to call it, will lead in some cases to fatty infiltration and progress to cirrhosis. Now, patients who have acute cirrhosis can seem asymptomatic, or they may have symptoms that include nausea, flatulence, ascites, light-colored stools, generalized weakness, abdominal pain, varicose veins on their abdomen, or spider angiomas on their abdomen. Classical presentation is going to be that hepatomegaly, that enlarged liver that we talked about, jaundice, they're going to start to turn orange, and ascites. Chronic cirrhosis symptoms include nausea, anorexia, weight loss, jaundice, dark urine, fatigue, and again, those varicosities. We see varicosities around the esophagus and also around the spleen. Chronic cirrhosis can progress to liver failure and to portal hypertension. Now we're going to talk about a few things that are a little more uncommon. The first one is glycogen storage disease. This is an inherited disease characterized by abnormal storage and accumulation of glycogen in the tissues, especially in the liver and the kidneys, which would make sense, right? Because it's converted to glycogen in the liver. There are 6 categories, but the most common one is type 1, and that's also known as von Gierke disease. Sonographic findings for von Gierke's include hepatomegaly, which again is an enlarged liver, increased echogenicity, so we're going to see a brightness of the liver, and increased attenuation, so the posterior and deeper sections of the liver will be harder to visualize because the sound signal is getting weaker. You may even see adenomas in association with von Gierke disease. Adenomas are going to be focal disease. You can see one right here in the liver. See how it's sort of isoechoic to the parenchyma of the liver, but we get this hypoechoic ring around it. We got one there, and then we got a smaller one up here in the anterior portion, which is also disrupting the capsule of the liver. See how it's changing the contour of the anterior portion of the liver there. The final diffuse disease that we're going to talk about is hemochromatosis. This is a rare disease of iron metabolism, and it's characterized by excess iron deposits throughout the body, which then put a heavy burden on the liver. They can lead to cirrhosis and portal hypertension. Sonographic findings are going to include hepatomegaly, evidence of cirrhosis, and also an increased diffuse echogenicity to the entire liver. Now, the thing about hepatomegaly and cirrhotic changes and even increased echogenicity is that they are not specific to hemochromatosis, right? We've talked about those same sonographic findings in most of the diffuse disease processes. So you're not going to be able to say this is hemochromatosis simply by the way the liver looks sonographically. Because so many of our diffuse diseases can eventually lead to cirrhosis and liver failure, we talk about portal vein hypertension in conjunction with diffuse disease. It's caused by an increased resistance to the venous flow through the liver. So as we talked about, right, that liver tissue in cirrhosis, we see it get necrotic, we get the fatty infiltration, then the liver tries to regenerate and restore itself, so we get overgrowth, and then we get scarring. All of this makes the liver very stiff and resistant to flow, and there's no pump behind the portal vein to push that blood into the liver. It's more of a passive flow. So with increased resistance, we see portal vein hypertension. It can be pre-sinusoidal or it can be intrahepatic. So it can be in the liver or it can be at the liver sinus at the porta hepatis where it starts. Okay. The hepatocellular disease blocks the flow of blood through the liver, and that causes it to back up into the portal system. So what happens is the portal system becomes hypertensive, just like any other, right? Like when you have high blood pressure. And in an effort to relieve that pressure, collateral veins, known as varices, start to form. Those we talked before about if the liver, if the pressure in the portal vein becomes too high, the flow is going to back up. It has to go somewhere. The spleen is where it's going to go first because it's going to follow that system, right? The splenic vein, the superior mesenteric vein come together to form the portal vein. If the blood is going to back up, it's going to back up into those two areas first. So we see varices form at the hilum of the spleen. We'll see them form at the esophagus, the stomach, and the rectum. Causes for portal vein hypertension. Any diffuse disease that leads to cirrhosis will cause portal vein hypertension. In addition to that, there can be metastatic liver disease can cause it, IVC or hepatic disease. So if we have blockage of the IVC or blockage of the hepatic veins, it's going to cause portal vein hypertension as well. Constrictive pericarditis. Again, if our downstream is blocked in some way, that blood has to go somewhere, so it's going to back upstream, right? So constrictive pericarditis, where the pressures in the right side of the heart become high, is going to cause portal vein hypertension, as is right-sided heart failure. Right-sided heart failure, same thing. If the blood cannot flow out of the liver and into the IVC and into the right side of the heart in the manner that it should, then it's going to back up into the liver is going to become congested, and then blood is going to have a hard time flowing into the liver. So what are you going to look for on ultrasound? We always check for hepatopedal or hepatofugal flow in the portal vein. Remember, hepatopedal is towards the liver, hepatofugal is away from the liver. So we need to know which way the blood is flowing. We want to measure it with pulse wave Doppler and get a velocity. We want to look for splenomegaly. Is that spleen becoming enlarged? And then we look for those varices or collateral vessel formation. We're going to look for those spider angiomas, caput medusa sign, splenic varices, which are going to be enlarged, dilated, highly vascular veins around the spleen. Those are the things you're going to be looking for. You may see that the liver itself has become enlarged because of the congestion, so you may see hepatomegaly. And then you're going to see that the portal vein, the main portal vein, has started to dilate. It's getting very prominent because of that increase in pressure, intramural pressure. And remember, the walls of the veins are very thin. And then lastly, you may see thrombosis of the main portal vein. So you may actually see blood clot in the main portal vein. Here we have a pulsed and color wave Doppler of the portal vein. We can see that the flow is into the liver. It's hepatopedal, partly because it's red and partly because our pulse wave is showing it above the baseline. Remember, we can't say for sure that red is toward the liver unless we can see the color map, and in this case we cannot see the color map. However, the pulse wave Doppler shows us that it is moving towards the liver because it's above the baseline. Recall in the last lecture we had a portal vein that was very smooth here. It looked more like this, right? It went straight across and it's not doing it. Let's try again. Nope. All right, hold on. We got this. We got this. Okay, let's try this. Right? There was this straight across sort of line like this, and everything below it was white, right? All of this was white. So we had a very even flow before. Now what we have, I'm going to erase this, we have this up and down flow, right? We get this almost pulsatile flow. And the reason is we're getting increased resistance in the liver to venous blood flow. So it's harder for that portal vein to push blood into the liver. Now over here in this picture, we have thrombosis of the portal vein. That's what the arrows are pointing to. It's very hard to make the portal vein out in comparison to the rest of the liver. We got something sort of called hepatization of the portal vein. Here's our portal vein right here. I'm going to trace it. In fact, I'm going to go ahead and actually trace it. This is the portal vein. Okay, you can see it coming into the liver here and going back out here. Now, it looks the same as the liver, doesn't it? That's because we have hepatization of the portal vein, because this is all blood clot in there. It can be very difficult to see blood clot in the portal vein. So if the portal hypertension becomes too extensive, the portal system can be decompressed by shunting blood to the systemic venous system. So what this means is they put in a shunt that goes from the main portal vein at the portosplenic confluence or at the hilum, at the porta hepatis, and they put in a shunt or a bypass, so to speak, that goes straight into the IVC or into one of the hepatic veins, and that way blood does not have to filter through the liver. It just goes straight from the portal venous system into the hepatic venous system. This does come with some problems because you can overload the heart, because all of a sudden it's getting a lot more volume from the hepatic venous system than it's used to. So you have to be careful with that. There are three types: portocaval, mesocaval, and splenorenal. And these are just really talking about where they come from and where they go. So portocaval goes from the portal vein to the IVC. Mesocaval goes from the mesenteric vein to the IVC. Splenorenal goes from the splenic vein to the renal vein and then into the IVC. The TIPS is a transjugular intrahepatic portosystemic shunt. This is one that's going to attach from the portal venous system through the liver and into the hepatic venous system or the IVC directly. And these ones are going to be seen within the liver parenchyma, and we can check those to make sure that they are working correctly. They're going to have very echogenic walls when you see them, and they're going to be curved. You should be able to follow them all the way from their origin to their insertion. When we're talking about diffuse liver disease and hepatic parenchyma stiffness and hepatocellular failure, we have to talk about Budd-Chiari syndrome. This is a syndrome caused by thrombosis of the hepatic veins or the IVC, so they become obstructed because of blood clot. It's an acute problem most of the time. It can be chronic, but most often it is acute, and it's characterized by abdominal pain, massive ascites because the liver becomes congested quickly and also fails quickly, and hepatomegaly. Folks with Budd-Chiari syndrome have very poor prognoses. The presentation, as we said, can be acute or it can be a chronic illness that lasts from a few weeks to several years. Typically, though, we're going to see that these patients have a poor prognosis, and within weeks or months of the onset of symptoms, it is usually fatal. A little bit more on the symptoms of Budd-Chiari. You're going to see ascites, abdominal pain, hepatosplenomegaly. So both the liver and the spleen may be enlarged. These patients are usually extremely jaundiced. They're going to have vomiting and diarrhea. Causes are things like renal cell carcinoma, primary cancers of the liver, thrombophlebitis, and migraines and polycythemia can also become problems with Budd-Chiari. When we find thrombus in the IVC, the edema of the legs is going to be very noticeable. Both legs will have gross edema, and the venous distension will develop over the abdomen, the flanks, and the back. So they get massive ascites, and you may even see caput medusa on these patients, which is like spider angiomas on the skin of the abdomen. Most of these patients are going to have albumin in their urine as well. All right, another cause of liver disease is going to be biliary obstruction. This is can be proximal or it can be distal. If it's proximal, it's caused by gallstones or cancer in the common bile duct. It can be metastatic disease of the porta hepatis. Distal to that, we're going to see stones in the common bile duct. We can see extrahepatic masses. These are masses outside of the liver that are in the porta hepatis or close to the common bile duct and impinge on the common bile duct, causing stricture. The other places that you might see it are going to be at the head of the pancreas, from the lymph nodes. Pancreatitis and pseudocyst are common causes of extrinsic compression of the common bile duct, or even carcinoma of the pancreatic head. Common duct stricture, we see this in patients who have had previous cholecystectomies. So if they've had their gallbladder removed and they've developed scar tissue or adhesions that have sort of squeezed off that common bile duct, that would be duct stricture. And then also passive hepatic congestion. We talked earlier about right-sided heart failure. So passive hepatic congestion is a slow building chronic backing up of blood into the liver because the pressures in the right side of the heart become too high. So we get so then we see that congestion secondary to congestive heart failure. That takes care of our diffuse diseases. We're going to move into different focal hepatic diseases, and the first one we're going to talk about is cysts. Cysts are probably the most common thing you're going to see, simple hepatic cysts. They're usually solitary, they're non-parasitic, they're going to have all the characteristics of a simple cyst. So they're going to be anechoic with a well-defined border and posterior acoustic enhancement. We can see this posterior acoustic enhancement in this picture. We've got our cyst right here, nice and anechoic, clear. We got that well-defined border, and then behind it we got this area that is bright that's caused by that posterior acoustic enhancement. Patients are usually asymptomatic. There's no treatment necessary for these. They can be solitary, or you may find them in pairs or even multiples. And we already talked about sort of those characteristics of a cyst. Now, there are different kinds of cysts. The first one we looked at was a simple hepatic cyst. What you're looking at here are peribiliary cysts. They're located centrally within the porta hepatis at the junction of the right and left hepatic ducts, and they can range in size from very small, just 2 millimeters, up to 2.5 centimeters in size, so from 2 to 25 millimeters. And most commonly we find these in patients who have severe liver disease. You may see obstruction if the cyst becomes large enough to block off those hepatic ducts. Okay, so we're going to see here we got, let me put on that, there we go. Okay, right, these arrows here are pointing to a multitude of little tiny cysts inside this larger region that I'm circling now. You can see 1, 2, 3, 4, 5, 6, at least 6 little cysts there. And remember we said we find this often in the presence of biliary obstruction. So you'll notice here we've got a gallstone in the gallbladder. I'm trying to move this along because we're already at 35 minutes and I like to keep these under 30. Let's talk about polycystic liver disease. This is an inherited autosomal dominant pattern. We see it in about 1 in 500 individuals, and at least 50 to 74% of patients who have polycystic renal disease will have 1 to several hepatic cysts as well. So you've got to, if you see cysts in the renal area, you need to look at the liver as well. Patients with polycystic liver disease, 60% of them, as I said, are going to have that polycystic renal disease as well. Typically the cysts are going to be small, less than 2 to 3 centimeters. They're going to be throughout the hepatic parenchyma. It's going to look a little like Swiss cheese in there, which is what you're seeing here. This whole thing here is all liver, and it is full of cysts. We've lost that pretty homogeneous liver parenchyma. Because of that, if the cysts get large enough, we can also see biliary obstruction in the porta hepatis. So just as abscesses can form from infection in other parts of your body, you can get abscesses in your liver as well. Pyogenic means pus-filled. A pyogenic abscess is going to be filled with pus caused by a bacterial infection. Sonographic appearance is probably going to vary, but typically you're going to see something cyst-like with possible interior echoes in there. Those interior echoes are the pus-filled areas. It may be cystic with some echogenic debris, or you may see that the whole cyst is filled in with pus. All right, hepatic candidiasis is another focal liver disease, and it is caused by a species of candida. This one is going to occur in immunocompromised patients, so patients who have HIV or full-blown AIDS, organ transplant recipients, and also those undergoing chemotherapy. It's a fungus, and it invades the bloodstream and can affect any organ, but it likes the ones that have more perfusion or have greater blood flow, so things like the kidneys, the brain, the heart, and the liver. Chronic granulomatous disease is a congenital defect, an immunocompromising defect that causes problems with the phagocytes, which are the cells that kill bacteria. So it renders them unable to kill the ingested bacteria, and that results in increased susceptibility to severe infections. Mostly we're going to see this in children, with a more frequent occurrence in girls. And what you're going to see are poorly marginated hypoechoic masses with posterior acoustic enhancement. So you might see it's going to look very similar possibly to a pyogenic abscess, but you're not going to be able to make out nice clear borders. Okay, they're going to be sort of fuzzy. If you get calcifications in there, you're going to see posterior shadowing with those calcifications. And typically, we can't say for sure that this is granulomatous disease unless there's aspiration of the mass. Okay, amoebic acid abscesses are similar in appearance to pyogenic abscesses, but they have a different cause, right? The pyogenic abscess is caused by bacteria. Amoebic abscesses are caused by protozoan parasites. And what we're going to see is a collection of pus in that disintegrated tissue, and it's usually going to be in the liver. Okay, so it's going to have that hypoechoic to echogenic debris look. We can see here, here's our nice abscess. The borders are a little fuzzy. All of this stuff in here, right, echogenic debris with some areas of liquid and necrosis. And they're reaching the parenchyma via the portal vein. So what happens is we ingest the cysts in either contaminated water or food, and then the amoebas are going to travel through the portal vein, through the bloodstream to the liver, and that's where they're going to settle. Okay, echinococcal cysts. These are an infectious disease common in sheep herding areas of the world. The echinococcus is a tapeworm, and it infects humans as the intermediate host. Okay, so it resides in the small intestine of dogs, and what happens is, right, the dogs, it gets through the canine feces into the environment. So in the contaminated water again, in the field, the crops where they're doing that, or even just through poor hand hygiene, it's going to end up in the intermediate host when we ingest the eggs. Now, after entering the proximal portion of the small intestine in humans, it burrows through the mucosa, enters the portal circulation, and travels to the liver. In the liver, it's going to form echinococcal cysts. There are going to be two layers, right? The inner layer and the outer or inflammatory reaction layer. You may even see smaller daughter cysts develop from the inner layer. They can be very large. If they get large enough, they can rupture. That can lead to fatal problems in the liver if they take over too much of the liver parenchyma, or if they rupture and cause serious hemorrhage. So they can impinge on the blood vessels. They can lead to vascular thrombosis. So again, we can see Budd-Chiari sometimes develop in these patients. Remember, we said we can get thrombosis of the hepatic veins or the IVC, and then we end up with Budd-Chiari. And also infarction, which is an interruption in the blood supply to the organ, in this case the liver, which then leads to tissue death and necrosis if it goes on long enough. Pneumocystis carinii is another one you're going to see in the presence of immunocompromisation, so HIV patients, patients who are undergoing chemotherapy, transplant patients. This is a opportunistic pneumonia. Pneumocystis pneumonia is a common infection, again, that we see in the presence of HIV. And it's going to have a starry night appearance, similar to what you might see with hepatitis, but what you're going to see are these hyperechoic little focal lesions throughout the liver. See them all there? Let me put on there we go, laser pointer there, up there. That covers our cystic things. Now we're going to talk about some things that are a little more solid. So the most common benign neoplasm of the liver is going to be the cavernous hemangioma. It's a congenital tumor. It consists of large blood-filled cystic spaces. However, sonographically, it's going to appear solid. We know that it's cystic and it has a bunch of blood-filled spaces in there, but it's going to appear solid. You can see it here as a hyperechoic mass in the anterior portion of the left lobe of the liver. Patients are typically asymptomatic, but a small percentage of them can bleed, causing right upper quadrant pain. Part of that is going to depend on the size of the hemangioma. The next one is focal nodular hyperplasia. I'm going to keep that laser pointer on. I'm just going to move it over a little because this one is hard to see. It's the second most common benign liver mass after hemangioma. Typically, it's also going to be a single, well-circumscribed lesion. There might be more than one mass, but often it's just a solitary mass. And we may see increased bleeding in these tumors. Increased bleeding can occur within the tumors in these patients. So here is our liver. Okay, here's the IVC. And right here is that mass isoechoic to the liver. There's a hypoechoic ring around it that allows us to see the margins. Let's just mark those margins with a red pen. Here we go. Right here is your focal nodular hyperplasia. Next up is the liver cell adenoma. You're going to see an increased likelihood of this in patients with that type 1 glycogen storage disease known as von Gerke. It's a tumor of the glandular epithelium, and the cells of the tumor are going to be arranged in recognizable glandular structure. But what's important for you to notice is that it's going to be solid appearing. It may have a lobulated border. So see how that border is kind of irregular? And they can be anywhere from hypoechoic to hyperechoic. So they have varying appearances sonographically. All right, we're getting close to the end here. We do want to talk about hepatocellular carcinoma. This is the most common primary malignant neoplasm of the liver, and presentation is going to be in one of three patterns. It can be a massive solitary tumor. There can be multiple nodules throughout the liver, or you can have a diffuse infiltrative mass of the liver. So pathologically, the tumor can present as a focal lesion, an invasive lesion with necrosis and hemorrhage, or as a poorly defined lesion. You may just see a lot of heterogeneity to the liver parenchyma. You'll be like, this is just not a pretty liver. It doesn't have that nice, smooth, homogeneous parenchyma, but it can't actually make out a mass. That might be a concern for hepatocellular carcinoma. So here's just a few of the ways that it may appear. You can see here in this first one, we have an isoechoic mass here, but we also have another border here that's a little harder to make out, and we lose the border entirely up here. So this may all be mass up in here as well, not just this focal lesion right here. Here, we've got more of a focal lesion that we can actually make out borders on. And then over here, you can see the liver just has a very not pretty, not smooth appearance, right? We get this sort of like mottled appearance without being able to say definitively that this is a mass or this is a mass. So we've got to talk about metastatic disease. This is metastases to the liver. The primary places where we're going to see it metastasize from are going to be the colon, the breast, or the lungs. It's the most common form of neoplastic involvement of the liver. And typically, once we see liver mets, the survival rate becomes very short. The prognosis is very poor. Carcinoma of the pancreas, stomach, and esophagus will also metastasize to the liver. It can have a number of different appearances, but what you're mostly going to see is multiple lesions. That's going to tell you that there's more going on than just a single solitary liver tumor. They can be hyperechoic, as we see over here, hypoechoic, like this one, or even some form of combination. So we can see there's a little hyperechoic lesion here. There's another tiny one here. We've got something right here that I can't quite make out, but there's definitely a mass there. And then we've got this mass here that looks like it started out hyperechoic and now has a necrotic center. Next up is lymphoma. This is also a malignant neoplasm that involves lymphocyte proliferation in the lymph nodes. We got two different kinds, Hodgkin's lymphoma and non-Hodgkin's lymphoma, and they're differentiated through biopsy. There's no other way to tell them apart, especially not with ultrasound. Often patients who have lymphoma are going to have hepatomegaly with normal or diffuse alteration of the parenchyma. So they may have diffuse liver disease in conjunction with the lymphoma. Focal hypoechoic masses are sometimes seen. Patient symptoms may include enlarged non-tender lymph nodes, fever, fatigue, night sweats, weight loss, bone pain, or an abdominal mass. And we will often see splenomegaly in the presence of lymphoma. The presence of splenomegaly or retroperitoneal nodes can help confirm that diagnosis. So here's an image of a patient whose liver has been invaded with lymphoma nodules, and you can see it looks very similar to Mets. It can be very difficult to tell the difference merely with ultrasound. And then finally, we have to talk about hepatic trauma. So the liver is the third most commonly injured abdominal organ after the spleen and the kidney. You can see laceration of the liver in about 3% of trauma patients. These are patients with motor vehicle accidents. I've seen patients with liver trauma from bull riding, being kicked by a horse, motorcycle accidents, falling off of a roof, anything like that. Any significant mechanism of injury can cause a laceration of the liver. Need for surgery is going to be determined by the size of the laceration, the degree of the hemoperitoneum, so how much blood is there in the peritoneum, and the patient's clinical status. What do they look like? Are they stable or are they starting to go downhill? The right lobe is going to be affected more often than the left, which makes sense. It's larger than the left. And the degree of trauma can vary, ranging from very small lacerations to large ones with a hematoma, a subcapsular hematoma, or capsular disruption. That concludes our discussion on liver pathologies. I apologize, it was a very long lecture. My recommendation to you is maybe try to put these into chart form so you can separate the diseases into diffuse versus focal, and then maybe even break them down from there into cystic versus solid or something like that.